the final 2020 Public Health Grand Rounds. We're so excited that you could join us. This is a great event this evening entitled Meet Them Where They Are, Public Health in the Emergency Department. And we've just had a really great series switching from in-person to online. So thank you so much for joining us. And throughout the event, you're going to see little polls that pop up, and we would love for you to participate in those polls. Oops, for some reason it's not, there we go. So the purpose of these events is that we really want to address important health issues and public health issues in the Philadelphia region. And we draw from local speakers who have expertise across disciplines and perspectives. And it's really to generate new ideas and strengthen the public health community in which we are working and living. We would like to thank our co-sponsors, the College of Physicians of Philadelphia and the Philadelphia Department of Public Health, and acknowledge the generous donation of the Independence Foundation. There will be a brief question and answer session following our panel presentation. However, we encourage you to really get involved. You can submit questions through the Q&A feature on the bottom of your screen, or you can chat along in the chat box and we can respond to you. You can respond to each other. So we really encourage you, and we'll be posting some things there for you to see also, some extra references. And so again, there'll be some polls that pop up throughout the presentation that we really encourage you to participate in. And an evaluation will be emailed following the event, and we encourage you to also complete that so we can continue strong programming. And if you're interested and have any abilities to support the section on public health and preventative medicine, we encourage you to become a member or support through other donations. So thank you so much for joining us this evening. And these are our institutional sponsors. And I'm going to hand it over to Dr. Priya Maman. Thank you.
Hello, everyone. Thank you so much for joining us. I know everybody is Zoom fatigued. I know our speakers have been busy at work all day, as have our audience members. So I do very much appreciate you joining us. And I will be honest, I am just over the top excited about this panel and our event this evening. I'm Priya Maman. I'm an emergency physician and public health specialist. So this topic in particular is exactly my cup of tea, as it were. I'm also the chair of the section of public health at the College of Physicians and a trustee of the College of Physicians. So I welcome all of you, especially if this is your first event with us. And I encourage you all, if you're interested, to please join our section. We have a very dynamic group of really experts across the discipline of public health, which includes medicine, nursing, all of allied health, the public health world at large in Philadelphia, and we are the largest member group in the city and region. So as Dr. Rexing said, this program is something that we have done in partnership with the Philadelphia Department of Public Health, and the Independence Foundation has been graciously supporting us as well with additional funding. And we have used it to really bring to our audience, which is not just the academic realm, not just the public health realm, but really the community at large, to bring public health issues into a realm that we all discuss that is timely and that is salient. And I could think of nothing more salient to end our 2020 season with, as the discussion combining emergency medicine and public health. This year in particular, both have come into a different realm, I think, of awareness, and frontline providers have been doing everything that they do, and the public health world has been doing everything that they do. And you know, in the unique nature of our work, when we do it exceptionally well, nobody notices us. And when crisis is happening, everybody notices us. And I will say, absolutely, I am filled with pride at this, with both cohorts, really, and particularly the cohorts that work together, for how everybody has navigated this year. But to not belabor the point, I would like to introduce our fantastic panel of speakers for this evening. And really, I think, conveys both the cross section of what we're talking about when we're talking about meet them where they are, which is, for my harm reductionist colleagues in the audience, is a mantra that we use in harm reduction, but it is most certainly kind of an underlying idea in those of us who kind of capitalize on the role and space of the emergency department to reach the population in other ways beyond acute care. So tonight we have really, again, just a fabulous group, beginning with Dr. Brendan Carr. Brendan Carr is the professor and chair of emergency medicine at the Icahn School of Medicine at Mount Sinai and the Mount Sinai Health System. Dr. Carr is a renowned emergency physician and health policy researcher whose work has focused on building regional systems of care for emergency care and developing innovative delivery system solutions to create a more distributed and accessible acute care delivery system. Dr. Carr joined Mount Sinai in February of 2020, 1 month before the first case of COVID-19 hit New York City, which seems like a lifetime ago. But he has been central in his role in coordinating the health system's response to the epidemic and has received national acclaim for the same. Dr. Carr holds a master's degree in clinical psychology and in health policy research, has received funding from many different federal agencies, private agencies, and foundations. His research focuses on the systems of care for trauma, stroke, cardiac arrest, and sepsis. He has authored more than 150 peer-reviewed publications, received numerous awards for teaching and research, and has advised and supported global non-for-profit foundations, including the World Health Organization and the National Academy of Medicine. In addition to this academic portfolio, Dr. Carr has served as the director of the Emergency Care Coordination Center and a senior advisor within the U.S. Department of Health and Human Services from 2012 to 2020. His federal portfolio focused on improving trauma and emergency care services at the national level and included working with the Department of the VA and the Department of Defense to integrate military and civilian healthcare response during disasters and public health emergencies. We will be hearing from him shortly. I don't think I've actually ever shared this story with Dr. Carr, but I first met Dr. Carr at the College of Physicians when I was a first-year medical student, and I think he was like a third or fourth-year medical student. And so here we are 20 years later, back at the College of Physicians, now virtually, but we've come full circle. Next, we have Ms. Corinne Mathurin. Ms. Mathurin is the senior director on the focus team with oversight over multiple focus projects within Gilead Sciences. Prior to being the senior director, she was the regional lead in Washington, D.C. Ms. Mathurin joined Gilead Sciences in January of 2010 from her position as the chief of staff of the D.C. office of the HIV/AIDS, hepatitis, STD, and TB administration. Her experience has enabled her to effectively navigate the complex political and policy environments in DC, as well as leverage her relationships with key stakeholders critical to the success of focused programming. Ms. Mathurin brings extensive experience in organizational management and program oversight. She has served as the Deputy Commissioner at the New York City's Department of Homeless Services and the agency's Assistant Commissioner for Policy and Research. Ms. Mathurin holds a Master's of Science in Social Work from Columbia University and a postgraduate certificate in nonprofit management from Columbia School of Business. Next, we have Dr. Kendra Viner. Dr. Viner is the director of the Division of Substance Use Prevention and Harm Reduction at the Philadelphia Department of Public Health. Her team works to reduce the number of people initiating use of illicit opioids and other drugs while ensuring that individuals in active addiction are receiving the harm reduction and treatment resources they need. The division manages and analyzes data on local drug use and its consequences, including overdoses, hospitalizations, and drug treatment utilization, and prepares summary reports and statistics that are used to inform city policy and initiatives. Her programs include neonatal abstinence syndrome surveillance and outreach, overdose death review, surveillance and epidemiology, communications, prescriber training and education, and treatment linkage. Next, we will hear from Mr. Jermaine McCrory. Mr. McCrory works as a community health worker peer with the Healing Hurt People program from the Center of Nonviolence and Social Justice. Mr. McCrory engages with individuals in the hospital and community, providing case management and peer support while utilizing his role as a certified peer specialist and experience as a survivor of gun violence to help individuals recover from symptoms of PTSD and complex trauma to ensure recovery. Mr. McCrory has been working with the Center of Nonviolence and Social Justice since 2011, first as a client receiving services with Healing Hurt People, and now as one of their champion peers. And finally, but certainly not least in any way, we have Ms. Elena Gouray. Ms. Gouray is the opinion coverage editor at The Inquirer, where she edits op-eds, essays, and other commentary. Previously, she was print managing editor at the Pacific Standard magazine in Santa Barbara and a freelance science and commentary writer. In a past life, she received her master's in cognitive science from the University of Edinburgh, and she has moved to Philly with stops in between to her Maryland hometown 3 different times. So we keep grabbing her. So with that, I will lead into this fantastic panel of speakers. Again, I encourage you to, the Q&A at the end is really when we have a robust discussion, and we will send out, continue to send out polling questions and evaluations at the end. So I encourage you all to stay till the very last minute. We might go a little bit over because we have so much to talk about. But with that, I will leave it to Dr. Brendan Carr to take us to the next step.
Thanks, Priya. There you go. So thanks, everybody. It is great to be back in Philly. I can feel like I'm sitting in that big hall at the College of Physicians, even though I am not. I don't know how to advance these slides, guys. If someone could give me control. Perfecto. Thanks very much. So I mostly wanted to say, first off, that you should be very careful what you put on the internet. I'm sorry, Priya, that you had to read all of that. Mostly, I am a guy from Philadelphia, and I wanted to just for a moment here give both my disclosures and my background, mostly because I looked at the participant list, and there's a lot of good friends from the Philadelphia area that are here. So I've med school at Temple, and then residency and fellowship, and a long time on the faculty at Penn, followed by a stopover at Jefferson for several years, where I worked on the research portfolio and the delivery system portfolio. As Priya mentioned, I spent a bunch of time inside of the federal government, which helped to really understand the sort of big chessboard about how healthcare gets delivered and the regulatory side of it and the financial side of it. And then just started recently at Mount Sinai. It has been a wonderful new home for me. I'm grateful for all the new friends I've met here. I just want to start, so my job, I think, is to kick this off and to pull the Band-Aid off a little bit, and to say some of the things that we dance around when we are talking about public health and whether or not it has a place in the Department of Emergency Medicine. So this is an old timepiece by 2 good friends about this framing of patients as too impatient to wait for care. And I'm going to read to you. I won't do it often, but the doc asks, "Why did you come to the ER today?" And this question, emphasizing today, is common practice in the ED. It helps us to figure out how urgent a patient's illness is, but it's a little bit loaded. We also mean, like, are you really sick enough to be here? Couldn't you just wait to go see a regular doctor? And they just go on and say, behind the sanctimony is this cliche, this McDonald's medicine cliche. If you spend time in busy ER, and you'll hear this recurrent theme amongst the staff, that patients in the US, they just want what they want when they want it. They want their healthcare like they want their food served up speedily and made your way. This conventional wisdom around the fact that this drives some of the crowding that we see in emergency departments. And I want to start off just by talking about the fact that this is the way we think about the ED. And it leads to things like this, right? Forbes telling us that this is the fundamental problem in healthcare. What's broken in healthcare is that the emergency department costs too much, and and people go there and they shouldn't go there. A big priorities partnership saying that we could reduce all of the healthcare costs associated with going to the emergency department if we just got rid of the overusers of the ED. And then my favorite word, who uses emergency departments inappropriately and when? And and it's a deep dive about all these terrible, inappropriate people that are seeking care from the healthcare system. There is a flavor that the emergency medicine community feels around this. There is a piece of this that I'm sure there's generosity that is around the fact that there might be a better place for people to get care. There's also a flavor of patient blaming, and it doesn't often get called out. And so this language around inappropriate ED visits. I will challenge you to use the word inappropriate in a gentle and kind way about someone you love. It is hard. And this was a Medicaid payment policy that was pushed through. And these are direct quotes from the Seattle Times, that Medicaid officials said the program's no longer going to pay for any medically unnecessary ER visits, even when patients or parents have reason to believe they're having an emergency. The ER can't be the medical home of the 21st century. We're not going to pay for diaper rash being treated in the emergency room. I mean, I guess, I would say those two combined, people who believed they were having an emergency, and diaper rash doesn't often manifest as diaper rash, right? It manifests in a new mom as a child screaming in pain and some terrifying red things that all over their bottom that you don't know what it is. The ER physicians and hospitals, and this is sort of this idea that physicians and hospitals have been intentionally abusing their privileges as providers of services for years, really sort of frames this issue in a way that I think is payer-centric and doesn't lead to sort of the team building and the relationship building that is necessary if we're going to advance the care of folks. A different frame on this is the patient's voice. And so this is, kudos to Kristen Rising, who's the lead on this. She's faculty at Jefferson. She's an extraordinary researcher in your hometown. These are patient quotes. My doctor's office was today. I tried to go walk in so she could take me, but when I went there, they told me they couldn't take me. She was packed, so I had to make an appointment for her tomorrow. Came home, but I'm still feeling the symptoms and they were bothering me. And I don't know, I would just lose my mind. That's the reason why I got to go to the ER again, because if I can't see the doctor to tell her what's going on, then I got to go to the emergency department. This is really something for me. It's coming to the way that I can't take it. Another one, I was referred to the clinic, and the only problem with the clinic is that they don't have the facility. They don't have the laboratory facility that can bring me back the answers right away like the hospital does. I had to wait 2 days. So if I go to the clinic, I got to wait 2 days, and in 2 days' time, I could be dead. So, that's the problem with the clinic, because a lot of times they just say, if this is a true medical emergency, well, the average person doesn't really know. And finally, I didn't want to take a chance because I'm no doctor, I'm no nurse, I'm just a patient, right? So this, on the one hand, I see a disempowered person looking for help. And then I see this giant policy framing that says doctors and hospitals are inappropriately generating revenue by treating people who have minor to moderate problems. And so maybe we did it to ourselves. Once upon a time, this is the way, or many people I think still think of the emergency department this way. This saying is sort of, you can get this for a doctor, for a nurse, for a paramedic, for dispatcher, this idea that unless you have a life or limb threat, we're not here to, we're here to save you, not to kiss it. There you go. I'm gonna leave it out. I can't swear. And off to the right here, right? That's a resuscitation bed. That's a critically ill person that's getting a full court press resuscitation. But then it really ignores the fact that there's another flavor that we're talking about here. We have built a consumer culture in emergency medicine. We have big signs that say we're open. This is our wait time. And we take care of a lot of acute care. So the blue, just to orient you here, this is a health affairs paper. It says where Americans get their acute care increasingly, it's not at the doctor's office. The blue here are acute care visits. So that's a new visit for a thing. Whereas the yellow are routine follow-ups and or some other sort of scheduled visit. And then for the top one, so showing you that emergency departments do more acute care than any other specialty, despite the fact that we are a relatively modest number of providers. And it's broken up into during office hours, after hours, and on weekends, because it's one of the few places to get care, to get acute care. So one of the things that we always talk about is that everybody's low acuity. And I just sort of thought I would put this out there because it is that we frame it that way. It's all inappropriate. It's all unnecessary. It's all discretionary. People could just go to their doctor. You see the non-urgent here, 2 to 24 hours, 7 to 10% of the business. Semi-urgent, urgent, emergent. These are real numbers of people with real concerns looking for guidance, looking for us to be the broker of telling them if something needs to be done. And then, another piece, another sort of misconception is that it's just costly with no benefit. These are two really key landmark papers in the last year. One demonstrating that emergency department visits decrease 30-day mortality, obviously for the highly severely ill patients, it's more of a decrease. And the second demonstrates that it decreases costs, which is a little bit shocking to people. But if we aggressively manage you in the emergency department and avoid putting you in the hospital, although it's more expensive relative to doing nothing or going to an outpatient doctor's office visit, it is less expensive than putting you in the hospital. So when we start to actually use the data to think about whether or not we have built a thing that perhaps we shouldn't blame patients for going to, we can come to a different conclusion. I guess I would just say the consumer piece is real, right? The advisory board is an entity that helps to create best practices and give insights about what the healthcare delivery system is looking like or should look like. This is what consumers want from primary care. Now, when I sort of put a red highlight on many of the things that are happening in the emergency care setting, convenience is king, like it or not. It is that is how we deliver most of our goods in society. Same day appointments, Trump walk in and wait. If it's, I'm happy to meet you online. The one-stop shop means everything. I want to get everything done at once, right? It's all about convenience. It's less about the fact that you're fancy and that your credentials might mean a whole lot when I need a complex cancer surgery, but when I need something quick, I just need something quick. And so I guess I just wanted to, as with all things, throwing the wife under the bus is, I think, a path towards people's hearts. I was literally in bed and groceries got delivered at 10:45 because it's convenient, right? For the way that we live our lives. I don't know this idea that if someone needs care during off hours, or if we need groceries delivered between the 9 and 11 window, because our lives are a little bit crazy, that we should be framing this as inappropriate, right? We talked about inappropriate visits. I don't call my wife an inappropriate shopper. I'm very happy that we do this during when we can do this. So I guess I'm lobbying for an understanding of what emergency care is, and that understanding is that it is many different things. It really is. The pointy end of the spear or the tusk here, and this is the parable for those who don't know it of the blind man and the elephant, where they all grabbed a different part of it and it told them a different story. You grab the leg of an elephant versus grab the tusk of an elephant versus the tail. It is the high acuity life and limb threats. It is also the low acuity and the sick and the worried and the scared. It is a place where if you just need to get worked up real quick before you get admitted, your primary doctor refers you into. It is care coordination, population health. It is the safety net that does a lot of public health screening and intervention. And it is sort of the wall that will keep us safe from COVID and whatever comes next. The last piece that I'll say is that, we talk about population health a lot. And very often when we talk about population health, we hear about how a healthcare system is managing their population or an insurer is managing their population. But these are cutting up the population in a way that is not always fully reflective of the community and the population that needs help. And, in a lot of the ways that we think about a grocery in a school, a grocery store in a school, it's similar in many towns across America that's their hospital. And that's where they go. That's where they go when they need something. So I made a cheat sheet for all the different reasons as we lobby the public health community that we want to be your partners. I think these are some key criteria to be an effective partner to public health. You have to never, ever lock your door. That's us. You have to literally let anyone walk in at any time and you just take care of them. That's us. 24/7, 365. Social determinants are a deep underlier of much of our business. We are the safety net of the safety net. We're where doctors send you when they don't know what to do. Where police people bring you when they don't know what to do. And whenever a social policy fails, we promise you that it shows up on our front door and we'd be happy to try to find solutions with you. So I just wanted to say, all over the country, this idea of social emergency medicine, the idea of this intersection of public health and the social safety net, is training the next generation of emergency physician to fully recognize that, yes, our job may be sometimes to save you during a life and limb threat situation, but most often it is to help you to coordinate your care, to help you to get the answers that you need. And it really is sort of a different practice than it was once thought of. Thank you, guys.
Thank you so much, Brendan. Dr. Carr has a way of just bringing it down to the nuts and bolts that makes it so easy to understand. So we appreciate that. Next, we have Ms. Corinne Mathurin from Focus Program in Gilead Sciences.
Hi, I'm so happy to be here today. I am not seeing my arrow. Oh, okay, it's doing it by itself. Okay, let me just go on back then. I am here to talk about our Focus initiative. Focus actually started off as an acronym. It stood for being on the front lines of communities in the US. But as we talk a little bit further into this presentation, you'll hear that we've actually moved from just providing support in the United States to also providing support in Portugal and Spain. So what is Focus? Okay, Focus is a public health initiative that Gilead started in 2010 that really was seeking to find ways to implement the CDC recommendations for routine HIV screening that were established or put forth in 2006. In 2010, we found a varied response to those who were implementing this. Some hospitals implemented, some local community health centers implemented, but in varying degrees. We found that in some states like New York had some legislation on the books around it, but there was no real clear path as to how do you routinize HIV screening. We created a model, a framework on which we would anchor our work with our partners. We thought at first it would be best to work with community entities, FQHCs, a DMV. We implemented a screening program at the DMV. Why? We thought it would be good to see how people would respond in community to being offered a test. But what we began to see is that there was interest beyond what we thought would have existed. And we began to see that we were having missed opportunities by limiting our efforts to local community health centers and community-based organizations. Then we thought we might need to partner with a larger entity. We started thinking about hospitals, and in thinking about hospitals, we thought the proper point of entree would be emergency rooms. Let me tell you a little bit about our framework. Our framework is based on the acronym TEST, T-E-S-T. TEST, T standing for integrating testing so that it is a normalized standard of care. E, using the EMR to propel testing. S, systemic policy change, creating policies within an institution that drive the process. And then T, which stands for training, is really more about our CQI, continuously looking to improve it. We started in 3 cities, New York City, Washington, DC, and Los Angeles. And we had a small number of partnerships then. Today, we're at well over 370 partnerships. And I'll show you a little bit later how far we've spread since then. The model, the test model. We know that it is resilient. We know that many institutions find that it is very effective, but we cannot implement this alone. We have what we call our living toolkits, which are our regional leads that are central to various jurisdictions that lead the implementation of partnerships. Note that I keep using the term partnerships. Why? Those who receive funding from Gilead's Focus initiative, they're not awardees, they're not subgrantees, they are partners. There is continuous bilateral exchange of information. Our partners teach us what is necessary. Our ED partners taught us about prompt fatigue, EMR prompt fatigue. Partners told us how they could just be overwhelmed with different prompts being, jumping in their face. You need to do this, you need to do that. So they taught us that we needed to think of how do we do this? How do we get this to happen in a way that doesn't create more for our partners? How do we do this? How do we get it so that it is invisible to our partners? And what we learned through the leadership of our regional leads is that if we use the EMR to sort of create algorithms based on the presenting problem of a particular person seeking care through an emergency department, we would be able to then have a lab order be pre-populated for an individual that presents with a certain set of presenting problems. Some organizations have gone as far as to integrate it into their overall, integrate the policy that it is the institution's policy to implement and to offer an HIV test, or that an HIV test would be administered as part of their admissions, permission for treatment form. It is systemic. It is part of the fabric of the institution. It is not something that is separate and apart. It is integrated. And our regional leads are there to help our partners every day be able to troubleshoot together, be able to find stop gaps, be able to identify the most efficient way to reach the most number of people. If individuals are presenting for issues that would require blood draw, and their presenting challenges make it such that the algorithm propels forward to have an HIV test performed, then the test is performed, and we also help with the concern of, well, then what happens if the individual is diagnosed? Many emergency rooms did not feel that it was their purview and their responsibility to have to then link that individual to care. We provide the support for navigation. Navigators to help identify the diagnosed individual to successfully find access to medical care. Our regional leads are there to be technical assistants to our partners from start to finish. We also work with the regional leads so that they are able to then help create sustainable programs. We do not want our partnerships to provide service to a community, and then when our funding is no longer available, then the service is no longer available to the community. So the regional lead works with the leadership of the hospitals, the leadership of the emergency rooms to help craft pathways and to be able to identify other resources to help support these critical resources such that the service remains for the community. I spoke about HIV, but our model is such that we were able to layer on hepatitis B and hepatitis C in this overall system to providing routine blood-borne virus screening through the EDs. In so doing, we were able to move from a model that was detached from the medical systems. It's now integrated. It's not a separate standalone order. It is something that is part of routine integrated care in many of our partners. And then what we also have been able to do, we don't have dedicated testers. It's part of the overall flow, clinic flow. The phlebotomists in the laboratories are doing this many times. And if this is happening in some hospitals where they've chosen to adopt it system-wide, so you have patients who are being screened on the inpatient floors. You also have patients who are being screened in the behavioral health services or in the outpatient services. But we found that the point of entree through the emergency departments was the one that allowed us to find people who would have been otherwise missed, individuals who present for one thing, and in so having their HIV test performed, we find that there are many positives for both HIV and hepatitis C. And being able to provide navigation support allows us to be able to have people seamlessly linked to care. I should also let you know that Focus is a treatment agnostic initiative. We do not seek to find out what a provider and their patient choose to do for care. We just want to know that if someone is diagnosed, they are successfully linked to care. And we have found that once we cast our net through the ED, we're able to find a wide scope of individuals. I told you that we started in 3 cities. We are now in over 91 cities across the country. We're in 3 different countries. I told you, the US, Spain, and Portugal. Note where we are. Much of our partnerships are on the coast, and we're moving towards Central America, the central parts of America. We follow the data. The epidemiology of where cases are developing is how we decide which regions we'll go into. And as you know, these parts of our country tend to have dense populations with high rates of a multitude of medical challenges, HIV, HCV, and HPV being part of them. Our dashboard. So as I shared before, we started in 2010. Look at our growth in testing since then. We've been able to complete over 7 million HIV tests. This is data through June of 2020. Over 4 million hepatitis B tests. We have been able to link 83% of those diagnosed HIV positive to care, 71% of those diagnosed HCV positive to care, and 80% diagnosed HBV positive to care. We also think it's important to share what we're learning. So our partners are very deliberate in disseminating their best practices, disseminating information about how they've circumvented certain challenges and some of the results of different interventions that they've tried. And we've been able to do that not just across the country, but also across continents. It's interesting, for an initiative that started in local settings, community health centers, some CBOs, you'll find that most of our partnerships today are in hospitals. And when I say hospitals, they're predominantly in EDs, followed by community health centers, and then followed by other community-based organizations, which can include prisons, it could include jails, it could include courts, and we also have a host of others in community health centers. What we've learned is that the emergency department provides a wonderful portal of entry to be able to reach people who may not necessarily be seeking care around HIV, but do live in communities that have high burden of HIV and hepatitis C and hepatitis B. And through building on other services that are offered through the ED, we've been able to identify people who are HIV positive and who are able then to access the care that they need, such that now HIV is no longer spread. Focus funding, I should let you know, supports HIV, hepatitis C, and HPV screening and linkage to care to the first medical appointment only. Focus partners do not use Focus Awards for activities beyond linkage to the first medical appointment. Our partners definitely provide service beyond that, but Focus funding stops at the first medical appointment. We are thrilled to have been able to work with medical providers to be able to help advance the landscape around hepatitis B, hepatitis C screening, and most importantly, where we started with HIV as a portal of entree. And we find that the best way to do this is in an integrated form, using the EMR to drive the process to the degree possible, and then also to be able to provide continuous quality improvement and to have it be rooted in a systemic policy change such that it is not person-driven, it is a system-propelled initiative. I look forward to answering questions and hearing more from the rest of the panel.
Thank you so much, Ms. McLaurin. Next, we will hear from Dr. Kendra Viner, back closer to home in Philly.
Yes. Hello, everyone. It really is a pleasure to be here today. So the Philadelphia Department of Public Health has a long history of working with emergency departments within Philadelphia. Given my role within the health department as the director of the Division of Substance Use Prevention and Harm Reduction, I'm going to talk specifically about our partnership with EDs as it relates to the opioid crisis and larger drug crisis within Philadelphia. So this here shows overdose deaths by year from 2010 through 2019. And it was really beginning in 2014 that we started to see a sizable increase in fatal overdoses and other drug-related outcomes across the city. And these outcomes, including overdoses, have continued to rise over the years and have remained high for the last couple of years. So this shows fatalities broken up by the types of drugs that were found in the toxicology. You can see from these bars that opioids still make up the largest proportion of drugs involved in overdose fatalities. So the white portions of the bars are deaths involving opioids. The dark blue are deaths involving opioids and stimulants. And you can see that they make up the largest proportion of the bars. But we are also seeing a rise in the yellow part there in deaths involving stimulants alone. So this is really an indication that this has become a much larger crisis. We're not just talking about opioids alone here. There we go. Oops. Okay, so there are many ways that the health department has relied on its partnership with emergency departments. There are two that I'm going to talk about today that I would say are our primary ways that we're interacting. The first is through data, through syndromic surveillance. And this has helped us to detect new and emerging trends, and also to begin to get a first sense of potential overdose surges within the city. And I'll get into more of the details around this. The other way that we're partnering with EDs is in warm handoffs to treatment. And this is directly from EDs themselves, as well as warm handoffs from community-based mechanisms that, again, I will go into in a little more detail. So syndromic surveillance, for those of you who are not familiar with this term, basically is defined as the daily collection of chief complaint and ICD code information for patients who are seen at hospital EDs. And we received this for all Philadelphia area hospitals. Up until very recently, this has been used really primarily for early detection of infectious disease outbreaks. So it might be our first indication of the emergence of flu through flu-like symptom, through a cluster of flu-like symptoms, or individuals with GI issues or headaches or rashes, et cetera. It's really been just in the last couple of years that we've actually started to use this same data source to monitor overdose surges and other drug-related outcomes. And I'll show you some of the data around this. So this is data here on the left, which shows a number of emergency department visits for overdoses specifically relating to opioids or what are classified as unspecified substances from 2016, which is already when we were at kind of a high level of overdose rates within the city, through Q3 of this year. And you can see that we're seeing each quarter about 1,500 individuals seen in emergency departments around Philadelphia for overdoses that are non-fatal, which, you know, going back to the data I showed you earlier, fatal overdoses are really just the tip of a much larger iceberg as it relates to outcomes from the opioid and larger drug epidemics. The graph on the right is Philadelphia County broken down by zip code. And this shows the those zip codes where patients who were seen in an emergency department for an overdose live. And you can see that the darker blue zip codes are those that have a larger number of individuals who were seen for an overdose. And when you put this map alongside maps of fatal overdoses or other drug-related outcomes, they really mirror each other. So this helps us get a sense of what geographies in the city are being hit, again, most hard by the opioid crisis. We also have used syndromic data to look at the impact of particular events on drug-related ED visits. This is data showing the impact of the COVID stay-at-home order on ED visits. For the graph on the left is ED visits for overdoses, which are that's the orange line there, from the beginning of 2020 through the end of June 2020. And then the green bar there is individuals who came in seeking after withdrawal or seeking detox. And you can see that following the stay-at-home order, there was definitely a decline in the number of individuals who came into emergency departments for one of these conditions, but this really returned to baseline levels shortly thereafter. The graph on the right is interesting to us because it shows the number of ED visits involving crack or cocaine, again, over the same time period. And you can see that those dropped dramatically after the stay-at-home order and have remained low. And actually, if we look at data from June to now, they still are much lower than before the stay-at-home order. And this was data that triggered us to dig further into why this might be. So we spoke with our partners at the Drug Enforcement Agency in Philadelphia, and their theory is that there's less cocaine available. The supply of cocaine has been reduced as a result of borders being closed relating to the response to the COVID outbreak. And of course, with less supply, there's going to be less sort of negative outcomes relating to cocaine ingestion or snorting. So this is, again, something that we're tracking very closely. The thought is that once the border restrictions lift, there are going to be large amounts of cocaine probably flowing into Philadelphia and other jurisdictions, and we may see a spike in overdoses relating to this drug. Syndromic data also allows us to monitor trends in other drug-related outcomes and drug types. So the graph on the left is showing ED visits for drug use-related skin and soft tissue infections. And you can see the very disturbing trend here that in 2020, really in Q2, and this is probably directly related again to the stay-at-home order and maybe the reduction in services for people who use drugs, there's a huge spike in drug-related skin and soft tissue infections. The graph on the right is just an indication that in addition to opioids and stimulants, we can look at outcomes relating to other drugs such as hallucinogens. Outcomes for this have remained relatively stable, but again, this is just, we're starting to monitor ED visits for a range of drug sources across the city. So this got a little bit tweaked, but that's okay. The other way that we use syndromic surveillance is to detect outbreaks. So all hospitals within Philadelphia report in real time to what is called epicenter, HMS epicenter. And HMS epicenter has within it an algorithm built in that if there is an increase in overdoses at the level of particular counties across the state, particular hospitals, or particular zip codes, it will automatically generate an alert that is sent out to key individuals who need to respond to those outbreaks. And this is just an example of an email that we might receive of one of those alerts. When we receive one of these alerts, our next job is then to compare this data with other data sources that we have within the city. So looking at overdose fatalities from the medical examiner's office, looking at the number of naloxone administrations across the city from EMS data, and then other data sources that we have. We also have, and this is another really important partnership, is we have a group of ED partners from all of the major hospital systems within the city that we know that any of us, both the health department and any of the ED doctors, can talk to each other or to us about anything that they might be seeing that's an anomaly. So whether it's a cluster of cases within a short period of time, or from a particular geography, or a set of unusual symptoms, we'll immediately alert each other and begin to look within our own systems about whether we're seeing something similar. And then based on all these conversations and data sources, we can decide whether to send out a city-wide alert and deploy field units to particular areas to deliver naloxone or provide education, et cetera. So the other way that we're partnering with emergency departments is through warm handoffs. So warm handoffs are really defined as the direct transfer of overdose survivors and individuals who might be seeking help, in withdrawal, basically from emergency departments to drug treatment providers. More recently, this has been expanded to provide linkage to other services, social services, housing, food pantries, other types of needs that that patients might require. They've also been expanded to involve connections directly from the community and not only from hospital-based settings. So all Philadelphia emergency departments are in various stages of developing a mechanism or a method for warm handoffs. This is through a variety of funding modalities, some of which is coming from the city through the Department of Public Health, through the Department of Behavioral Health, and then their own internal funding sources. And each hospital system has really developed its own mechanism for warm handoffs based on the population it serves, its own capacity, built-in capacity for providing those services. And this ranges from building CRS units, social services for those CRS employees, building EHR capacity and the ability of the medical records system within each hospital to communicate with treatment providers, building capacity around training as it relates to stigma and harm reduction, protocols around improved naloxone dispensing. So there are a wide range of protocols in place that are really exciting to kind of see further develop. Based on a bill that was put into place earlier this year, all emergency departments report quarterly on the number of individuals who are seen for drug-related reasons in their ED, as well as the proportion of those individuals who are referred to treatment and other services. And we're really excited to say that we received the first quarter of data just a few weeks ago. And of the number of people who came into the emergency department for a substance use disorder related issue, over 85% of them were linked to some sort of treatment. So that is really wonderful news, and I think speaks to all of the amazing work that's happening in emergency departments around the city. And lastly, I think there's been an understanding, based on conversations that the Department of Public Health has had, the fire department, based on its interfacing with individuals directly in the community and emergency departments, that there are some individuals a proportion of individuals who overdose or who have other negative outcomes who will not seek help in an emergency department. And in fact, based on our data, it's up to 20% usually on a quarterly basis of individuals who receive naloxone from an EMS first responder who, after having received that naloxone and coming back from the overdose, refuse transport to an emergency department. So based on that gap, it was really through conversations with our partners that we realized that this was a gap that needed to be filled, that we needed to be able to interface with these individuals and provide them linkage to services that they weren't getting. And so this really led to the development of what became known as the AR2 unit. And this is a vehicle that goes out along with paramedics to respond to overdoses that occur primarily in Kensington, now in the Kensington area of the city. And if the individual refuses transport or is not interested in transport to an emergency department, the social worker and case managers who are part of this unit will engage that individual and provide them resources, naloxone, education right there on the scene. And then if they're interested, they will link them to housing, to treatment, to harm reduction resources, other things that they may be more interested in, or be at a stage of willingness to accept. So that is an extremely exciting resource now that the city has on offer. And that is it. I'm looking forward to discussion.
Thank you so much, Dr. Viner. Next, we have Mr. Jermaine McQuarrie from Healing Hurt People and the Center of Nonviolence and Social Justice.
How's it going, everyone? So, as you might have heard, I'm a community health worker peer with the program. Been working with them since 2011 as a client and a case manager. I'm trying to find out where's the cursor? Okay, got it. So what we do is we support, individuals, facing this public health crisis of violence. As you may see, many, face these violent injuries, gunshot wounds, stab wounds, have untreated mental health consequences. Some due to lack of education, some know what's going on with themselves, but just can't understand how to get help. Violent injury, and like it says, untreated PTSD from prior traumas and injury. And me myself, I'm a peer, and as far as communicating to individuals what the benefit of these supports and why they need the help. Here is the cycle of violence. This is what we try to interrupt as much time and work and sweat that we put in. So as some of you may know, some of you may don't, we're a hospital-based violence intervention program. We usually serve children ages 8 to 17, young adults from 18 to 35. The situation varies. Usually victims of interpersonal violence. We try to honor other areas of support that may be out there for individuals. Like it says, we're a part of Drexel's and the Center of Nonviolence and Social Justice. I'm happy to work with some fine gentlemen who you guys may know. We provide trauma-focused therapy, trauma-informed case management, because like what this panel is about, right? We meet them where they are, and that's what my definition of trauma-informed is. Like I said a minute ago, we and I try to interrupt this cycle of violence as much as possible. As it says here, after a violent injury is acute stress, PTSD. The person may not, have the knowledge of how to get help for this, for what happens right after these experiences. So they might smoke weed, just try to retaliate because they don't, that's their only way of doing things, or they might self-medicate because, it's pretty hard when you can't process what's happening to you. And, this limited education about supports anyway. Then goes to injury, retaliation, sometimes re-injury. Youth shot, gets stabbed, gets treated in the hospital. And this is where I and a program tries to become interrupters of this cycle, right? This is where I'm usually at in the ED, right? And I'm able to end up here as a median before they get to back to the street to help them utilize the supports some of you guys may have in place, and communicate to them what these are and why they need them, because some people can't understand what you guys are selling them. Might be language barriers. Some people are just uneducated and just not in that mode to process things that they can't understand because they're in the ED for a traumatic experience, right? So yeah, I try to engage them and help them, like, meet them where they are, but try to set myself as an example and lead them to supports that would benefit them in the immediate future before they're discharged. While they're discharged to the streets, because having education is better than going back out into there. So my bad if I stayed on this a little bit too long. So our team, the child team, is an engagement specialist. He's usually a CPS individual with shared lived experience who engages the individuals at the bedside, in the community, at schools, or in the ED. It depends on what the individual needs. We have community intervention specialists who are therapists, licensed social workers who provide clinical supports, therapy, trauma-focused cognitive behavioral therapy, and cognitive processing therapy also. And me, I try to communicate to people what these things are and try to help them understand, how these supports could be that we provide is beneficial to them in the moment. I also provide case management, advocacy, on mostly every day when I do this. And on the child team, we have a different community health worker peer who's working with the youth right now, who's not here right now. But for the adult team, we have an outreach specialist. Again, they're either talking and calling with individuals as they leave the hospitals and the ED. Community intervention specialist who specializes in therapy and cognitive processing therapy, and me, community health worker peer for the adult site. I've been doing this for quite a while, as some of you people may know. So a little bit more into what I do. I'm a case manager, advocate, try to be a liaison in communication, because most of these things and issues are prevalent, and most of these supports that are pivoted from the ED are important for individuals. Sometimes, most of the time, it's just how it's communicating in the way that they understand it. Yeah. So again, I may have said some of this, but our approach to trauma services, assertive outreach, connect with family members, community members, and try to just educate them about what happens and the supports that are out there. We connect them with mental health assessments, TFCBT, CBT, peer and case management supports, then discharge and aftercare planning. As I may have said, we try to meet as much basic needs in the moment with the individual to build trust and to help them I would say get them better to where they don't have to make impulsive decisions before they so they won't have to make impulsive decisions so they can have a healthy recovery. Where am I? I lost it. And so, yeah, I think this is where I'm at. Somebody help me if they could. But so some other things that we offer TFCBT, talk with individuals who provide therapy to individuals experiencing these trauma symptoms, PTSD, complex trauma. We have group therapy to where we facilitate conversations about, just trauma and like what it is and helping people process their trauma and what they have going on in their lives, and just to create space for expression for people to just get that stuff that they can't that they don't want to share to individuals close to them that they think may not understand. Again, peer services, just people with lived experiences who get it, who can, communicate, needs, healthy coping, trauma-informed case management. What did I do?
That's okay. We'll take over the slides. Thank you so much, Mr. McQuarrie. And I know that in the Q&A, I'm sure people will have specific questions for you, but thank you for sharing your experiences.
Oh yeah, most definitely.
And finally, but certainly not least, Ms. Elena Gray from the Inquirer.
Hey everyone. So you're probably wondering what I am doing among all these healthcare experts. And that's a good question. The answer to that is that my version of meet them where they are is to write an op-ed for me or any of the other excellent editors at the Inquirer's opinion team. So tonight I just wanted to quickly walk everyone through how an op-ed can be useful to you to reach a different kind of audience than you normally do, of diverse folks who can help you really make concrete change in your community on some of the issues discussed tonight. And I, hold on, am also having some slide issues. Here we are. So why write an op-ed for your local paper or a national one, but I'm here to plug local news especially. So one good thing for all of the professionals tonight to keep in mind is that writing for a general interest audience helps you reach folks that you might normally not, especially in all of our professional silos. So one, it's a great way to directly speak to patients and communities that you serve in your different healthcare settings. And two, you can also speak to potential collaborators on some of the issues that you work on. So for example, politicians, people in government, business leaders often have a hand in, intervening on some of the aspects of care discussed. And this is a way to be in conversation with them about moving forward. And it's also can be a really great way to have impact. So, in an op-ed that you submit to the Inquirer or any other paper, you can do anything from speak directly to patients about, for example, abiding by the stay-at-home and other COVID restrictions that we're all living with now, to speaking directly to, say, Philly's Office of Violence Prevention to be more transparent in the data that they share. So that's just a little bit of the flavor of the type of impact that you can have. So I'm going to breeze through sort of what we look for in the op-eds that we publish. We have our online guidelines. If you just Google Inquirer opinion guidelines, sort of that criteria will come up. But the three main things that we're looking for are relationship to news issues. So everything discussed tonight touched on content that comes up in the news cycle regularly. And so those are really good opportunities to speak to that broader audience about some of the longer term work that you're doing. Timeliness matters for us. We always want a compelling reason, why you want to tackle this issue now. And in general, for the Inquirer, we really like that local focus. So if you can give a sense of what the potential impact and stakes are for the Philadelphia communities, all the better for us. Okay, and then so a lot of you might be familiar with academic and other forms of professional writing. So I just wanted to highlight some ways that our medium is a little bit different. So op-eds are really tight. The standard length is 650 to 850 words. News moves faster than academia does. So typically, you know, we're working within a matter of days to get your message out there, which can be a little cruel for researchers and other forms of writers, but you know, we will hold your hand through it. And I think the most important thing that we try to do for people is to teach you how to translate your professional language and your really technical knowledge to a broader audience who, you know, of course, are not the experts in their fields that you all are, or in your fields that you all are. Okay, so I wanted to just give examples of some op-eds written by physicians that we've run in the past year that have been really effective. I'll stress that I've selected op-eds by physicians, including 2 emergency doctors tonight, to speak to our broader audience. But I want to stress that we take op-eds from literally everyone. So, you know, I love doctors, but they're not the only people that I work with. They're just who I picked for this evening. So first I want to highlight a good op-ed from our very own Priya Maman here tonight. Priya's written some really lovely personal essays for me, but I picked this piece because it's a really strong example of writing to have impact. And so for this piece, Priya decided to focus on a report from the Joint State Government Commission of the state of Pennsylvania, looking at the system of emergency care across the state and where EDs fit into that picture. And so Dr. Maman was able to highlight flaws in the report while also honoring what it tried to do. And so this is a really good example of someone bringing their specific expertise to bear in direct conversation with government officials who might be able to make change. And so the next op-ed that I'll highlight is from an emergency. I'm very trigger happy with my slides, excuse me. An emergency physician at Jeff who spoke directly to folks, emphasizing how important it is to pay attention to COVID restrictions. So this is a good example of an ED writing directly to patients. So that's why I wanted to flag that one. And the last one I'll highlight is from I want to say the chief of hospitalists at Jefferson Cherry Hill. And what I liked about his piece is that he opened with this really evocative scene of what it was like to get calls early on in COVID and have to come up with this emergency care plan. But then Dr. Verma didn't shy away from scolding politicians for being a bit cowardly in the way that they were handling some safety restrictions. So that's another good example of a doctor using this platform in a unique way to call for action. And so I will wrap up there because I know we all want to get to questions soon, but I encourage everyone to reach out to me if you have even just the germ of an idea for an op-ed at eager@inquirer.com. And I'm also on Twitter, so I hope to hear from folks.
Thank you so much. Thank you to all of our panelists. That was a tremendous amount of information very quickly. And as usually happens, I think each one could speak for an hour on their topic and people would still be very interested to keep listening. But we've kept it to very bite-sized bits of information and now really to engage the discussion with the group. But I will start just with a quick question. So Ms. Garay kind of highlighted what her role on this panel and as a whole piece is really the concept is the pivot. And I think each of us in our work, I will include myself just because I'm an emergency physician, but each of us on this panel has actually done that work of sort of making a hard pivot in what has traditionally been seen as the approach, and then what we've kind of done to meet people where they are and kind of have a greater impact. So perhaps we can just go through the panelists and kind of let me ask you, in terms of the pivot, what has been some of the hardest challenges you've met? Dr. Carr, you can start. Now you're the chair, but as you were working through your career, what were some of the challenges you met in terms of making the argument for the types of interventions and types of approaches that come through sort of the integration of public health and emergency medicine, but also, you know, speaking to policymakers, speaking to hospital administrators, and kind of making the pitch for this kind of approach?
It's super brutal. I don't want to say it out loud. Time and money, right? On the provider side, it's that I don't have time to sort of do the extra things that I need to do to get this person the care that they need for this, you know, non-medical, not directly medical thing, even though we all know that it is going to drive their trajectory around needing medical stuff. And then on the, you know, putting an administrator hat on, not talking to the providers, but talking to the administrative leadership, it's about the fact that, you know, we're largely talking about, you know, for many of these initiatives, not all, a portfolio of unfunded work. I mean, that you shouldn't ask me first. That's a brutal, cold reality. So what you're driven by then is the fact that, you know, most people that went into medicine because they genuinely want to impact the individuals and communities. But that is a little bit of a tough business model, which is why partnerships with, you know, folks like the people on the panel, bringing them in, giving them a home, or building a structure to offload some of either the financial responsibility or the time that it would take to get a comprehensive history and figure out how to give somebody, you know, the correct handoff, a nice warm handoff, or get plugged into a program for trauma survivors is a welcome partnership.
Thank you. Ms. Mathorn, you, as the focus program was probably the first, and even though here locally in Philadelphia, as Dr. Viner pointed out, the Department of Public Health has long recognized emergency departments and champions therein as key partners. But what are some of the issues, if you remember way back to the beginnings of Focus, that both Gilead and the Focus program was dealing with, but also how to make the argument to both government officials and the higher ups on how the approach from the ED was really, I'll use the term return on investment, but I say that specifically return on investment in terms of human life and impact. Dr. Carr knows I'm very bad at focusing on funding and finances. So the return on investment of where you put the investment into infrastructure development and what you get out on the side.
Yeah, I think that I can certainly build on what Brendan has said. One of the things that our partner, remember I said that we respond to what our partners are teaching us and what the emergency rooms are teaching us. So one of the things that we did learn early on, and is still an issue, is the reimbursement rates that many of our partners have to deal with. The capitated rates that that exists right now makes it such that it's not looked upon favorably to take on something that may not necessarily be reimbursed at its fullest. So where we're able to support public-private partnerships or partnerships similar to the ones that we do, we try to do that. And it's not just us, we also look to introduce some policy changes to help advance and elevate some of these challenges, and also be able to use different parts of our company to be able to educate legislators as well as policymakers around the necessity to be able to provide the necessary financial support to hospitals, especially to the emergency rooms, because if we don't address some of these issues from onset, it's more costly down the road. And that's something that just doesn't seem to add up to legislators and those who provide funding. I don't understand the resistance, but that is something that we continue to put forward, and our partners continue to ask us to elevate for them, because it's not beneficial to the community for the health of the institution, and then ultimately for the community at large. It's counterintuitive. So we don't quite get it, but to the extent that we can, we elevate those issues and we support our partners in helping them to sort of find the right platforms for them to be able to articulate and use the data collected to be able to sort of validate what their assertions are.
Dr. Viner, do you have anything else to add? I know we've had discussions about the champions, kind of those of us in EDs who have been champions, especially around the opioid crisis, kind of like raising our hand and being like, we're here, we need help, and we're happy to help you. And in terms of the department, it seemed that the data kind of overlapped with us. And it was kind of a natural marriage of partnerships. But what I can say, and to your credit, the Department of Health specifically, there have been efforts, plenty of efforts around the opioid crisis that failed to see what Dr. Carr was kind of pointing out. And instead of looking at how patients were accessing care or just ending up in care, focused on how the system had been set up to help them, which was, in the setting of the opioid crisis, almost antithetical in some ways. And the Department of Health was the first to say, okay, we're going to actually invest in emergency departments and fund these kinds of programs, because it's really where the greatest impact can be reached. So thank you for that as an emergency physician in Philadelphia, but also what are your thoughts in terms of some of the barriers you've met?
I think, aside from funding, which is obviously a huge barrier when you're talking about, local government or state government for that matter. But it's also, that making change happen, policy change, regulations, anything at this level is very slow. It wasn't until we started to see an uptick in overdoses, fatal overdoses in Philadelphia in 2014. It wasn't until 2017 that we had a task force convened to begin to think collectively as a city about how to address the opioid crisis. And, it's just because to begin to think about developing new programming and pulling in new staff, and that the ripple effects from that in terms of additional infrastructure that's needed to house new staff and get IT equipment set up, and all of that just takes so long that by the time you have everything in place, some months, years have passed, and you can really start before you can start to get boots on the ground. And so that's probably the most frustrating aspect. I think we're in a very good place now, although the COVID pandemic has really, as it has with everyone, really hindered our efforts pretty dramatically.
Thank you. So this question that's come in from the group is directed to Mr. McCory, but it's sort of a general idea. How many EDs use trauma support staff, and how much of that kind of support staff engages back into the community? It's a very unique model, and one I think that is sort of also the crux of warm handoffs, of having peers as opposed to just professionals. Excuse me. But Jermaine, how many people do you know, or how many EDs in the city have something like Healing Hurt People, or who have staff who meet patients after injury in the emergency department or in the hospital and then follow them outwards back into their communities?
There's definitely programs like that around, but what I do know is that we as a program go out to the communities and engage with individuals and families. From what I know, that from the hospitals that we do work with, they are accepting of trauma-informed workers, peers specifically, social workers. We're usually connected with their trauma intervention people. So, as far as their, trauma social workers, they're pretty open and supportive of our program and what we do. Mainly the problem is like getting buy-in from more hospitals and more community centers and maybe other places other than the hospital. That's what I could say about it.
Thank you. Going through some more. Dr. Carr, there was a question for you, which is, how have you seen the role of urgent cares impacting how people access care in the emergency department?
I typed a response. I think it's been huge. Urgent care has offloaded some lower acuity stuff to settings that make sense. It also has been pretty powerful in getting people to understand the different types of care that happens in different settings. People are getting to be very savvy, very smart consumers of healthcare. And just, a few years ago, that wasn't true. People just didn't think about how to right size what they needed to the right environment. It still leaves, especially in the public health space, huge gaps for folks that are in need and are looking for programs that address underlying drivers of their health. Those are generally not found in urgent care centers, although it's an amazing next partnership to think about. And I'll just sort of chime in as I'm sitting here thinking about this problem, and it's not the central thing that I spend my time thinking about, but I was sitting here thinking about what the role of the payers is in this. And I understand that, we're talking about very often a population that is not a private payer population. But I'm not sure that means that there's not a mechanism, that there shouldn't be a mechanism for them to contribute to this. Many of them would. Many of them have margins that, and they're looking for investment opportunities. People do bounce back and forth between being insured and uninsured, and being on public insurance and being on private insurance, and a little bit of investment in health might decrease long-term healthcare costs. I just don't know. Again, it's not my space. I don't know to what extent they have been engaged in helping to solve for this problem, but it does strike me that it might be something they'd be willing to contribute to.
So we do have a couple payers on this in the attendees. So I will say I have actually discussed some of these things with some payers in Philadelphia, and it's often the same narrative of, it's hard for some to understand what the return of investment is, because people have been so ingrained with the idea of emergency departments provide and not wanting to increase unnecessary use of the emergency department, and really seeing emergency departments as a very expensive point of care, as opposed to sort of a spectrum that's meeting the needs of the population, and that the population is actually sort of voting with their feet. And the way they're seeking out care is not driving it. The way it is perceived that they should seek out care is what is, more of a discussion.
I was mostly sort of talking about programmatic interventions. If we see them once and grab them, funding that programmatic intervention, even as philanthropy, or even as in the hopes that it's going to improve someone's health outcomes or decrease someone's long-term costs. That's where my head was. Priya, I don't know what to say that. Yes, I get it. Paying for the same visit over and over for the same problem is not something that anybody really wants to do. It's not a way we want people to live their lives, or to have to live their lives stumbling through our system over and over again. And we've all, those of us who practice medicine have all seen it. But boy, asking for investment in programs, but maybe it's a naive question, and maybe there are big philanthropy portfolios out of the big privates that feed all the programs that were mentioned here tonight.
To some extent. We have a response actually from Dr. Ted Corbin, who is one of our great champions of emergency medicine, an emergency physician in Philadelphia, who comments, the emergency medicine is the space where social determinants are and can be identified, and in moving towards value-based care. This should be something that payers should invest in, and Healing Hurt People has made some headway in this space. So that's a good thought. I'm sorry, I'm panning through these questions. Do not steal our people. There's a whole side conversation happening. I apologize. So let me go back to Ms. Garay. Elena, can you speak, when we do the writing, and here's where the pivot that I was describing earlier, Dr. Carr has written 150 articles and is sure to tell that it's very clear that he is one of the great minds in emergency medicine today. But for those of us who have been in academic medicine and who had been in the sort of role of thinking through how research is operationalized, opinion pieces and my writing, at least in the Inquirer, has been to really flip the switch of no longer being as interested, no offense, Dr. Carr, in my colleagues' opinions, but really wanting to teach the community or engage with the community in something that I felt that either I could bring voice to, and it was sort of dual-ended of the community plus the policymakers. So can you give us a little insight in terms of, let's just say the traffic, the clicking, however you guys track metrics or impact of a story from physicians, and what have been some of the things that you can remember just off the top of your head that has had greatest impact in terms of either the community or policymakers or just changing the narrative in general?
Sure. So I would say that trying to track impact, like so many things, is an art, not a science. So you've got the pieces that explode on clicks, and that's great because that means that they've reached a lot of folks. And I think those are often the pieces that have the clearest sense, to get back to something you were, Priya, of knowing who you're talking to. So for example, the piece of yours that I shared that was focused on community behavioral health care and mental health care systems across the state, sharing in Facebook groups and other interest groups that are really focused on that will give it reach. And, it's very clear to folks, I'm speaking to you about X issue. And then so it'll spread that way. I think one of the pieces of ours that did best was by a critical care nurse who wrote about a case in Tennessee, actually, of criminalizing a nurse who was held responsible for giving the wrong medication and a patient died. And so it was really talking about protections for those workers. And that exploded because I think that was an issue that looms over the heads of a lot of healthcare workers, but isn't really talked about. So those sorts of topics that have a very clear audience often do well for clicks. That's not the only metric or only determinant, but it's one I can think of. But then there's also the impact of a piece that maybe doesn't get 50,000 views in the first week, but finds the most meaningful audience. So I mentioned talking to Philly's Office of Violence Prevention earlier, and we had an op-ed from a researcher at Temple University who talked about what OVP could be doing to make sure that it's replicating the most effective aspects of gun violence prevention programs that Philly's already tried in the past. And after she wrote that op-ed, which, it did well readership-wise, but it didn't necessarily go viral, the Office of Violence Prevention, I think the next week, clarified their plans moving forward. So that's another version of impact of you're shaping policies that are directly affecting the community that you want to reach. So I hope that's helpful. I haven't cracked the exact formula yet, but those are some things that work.
That is helpful. Thank you. Do you, as panelists, have any questions for each other while I mine through these questions? And I think we will be close to wrapping it up.
While you dig through questions, I would ask Elena to maybe double down on that just a little bit more. It is so hard to translate these issues into something that is digestible to the public. And, I saw somewhere on one of your slides, you said, you might not have to write the op-ed. It turns out we do this for a living. We're very good at this. I guess I'm just sort of wondering about how we give voice to people that do see these challenges and work so hard. It's hard to get the attention of a reporter. It's hard to write an op-ed. No one reads the medical literature who's like, a regular person. We know that, and we don't know how to translate so often. I guess maybe I'm curious about, in addition to op-eds, the use of social media, where you stand on how to really influence the conversation. What we can, because someone else asked, as a regular person, what can I do? it does feel like amplifying the narrative is a piece of that. And we saw it happen all over the United States in the last couple of years, really. A lot of activism that came from the public.
Yeah, so I can, as in terms of op-eds and writing for your local paper, I flagged to that commenter that letters to the editor and other when you to do that. So one thing I would say, I think that's a big question. I would say that I would encourage folks not to be scared away by not being comfortable with a particular medium or particular type of writing. Because at least for my team, we always say that the idea is more important than whether you can write it perfectly the first time. We're really active editors who say, okay, maybe you're not, 90% of the people I work with aren't professional writers. And they, 99.9% don't have experience writing for a newspaper before. So I wouldn't want that to dissuade folks. But in terms of, to your point, about social media, I would never undercut the value of that in ways of reaching folks unfiltered, using that to lift up voices that aren't often platformed in sort of these mainstream halls of power, including mainstream newspapers. So I think that's a really long way to say that I think social media is another great way to join the conversation. And I would go back to what I said about knowing your audience, which is that social media seems the most effective when you know who you're talking to, because otherwise it can feel like you're shouting into the void. So whether that's talking to this sort of grand rounds community, talking to your harm reduction community on Twitter, whatever it is, that's really powerful.
Thank you. So this, we have one of our governmental partners. I'm not going to read the whole thing, but the key part is this. The EDs fill the gaps in some ways, but do any of the panelists have the pie in the sky ideas to bring healthcare to the community that they'd love to pilot if funding or policy restrictions were not an issue? That's like a ding, ding, ding kind of question. I expect funding as a result, and I know who you are. Any ideas, any thoughts on ways in which we could? So I'll go back to Dr. Carr for a second, because now you have a different hat as the chair. But for those of us in this space, in the doer space, we would love to maximize impact where people are. In the setting of COVID, and I think everybody could speak to this, this is like a whole new ball game. And I think all of us are trying to just navigate through that. But do you think the future of emergency departments and sort of the big picture is that we continue to find these ways of intervening in the acute care space, one, and then two, I open it up to everybody. What would be a great partnership or program or intervention on a local, regional, national level where EDs and the public health world can intersect?
I'm allowed to go first. We're about to have one. I mean, let's all cross our fingers that we're about to have one. We're going to need to vaccinate the entire American public, right? And that is going to be an all hands on deck initiative. We do home-based flu shots, right? Here and there. It's administratively complex. It's not for people that can't get out of the home. It's a lot of time and energy for one flu shot, but we need to scale it. And you're right. It's a whole new ball game. Everybody expects care either virtually or outside of the walls of the healthcare system. And that exists for two populations. It exists for a population where a healthcare system is in a specific kind of payment structure where they own all of the risk for you, the financial risk. So if they're at risk to take care of all of your needs and you get admitted to the hospital, it can break their bank. So they will send people out to check on you to keep you well. Or it exists if you're a billionaire, right? And you just figure out a way to get it delivered to your, all healthcare delivered to your front door. That whole middle ground there is all the rest of us. It's everybody, except for those two very small populations. And that is where the fun space is going to be. Everybody expects that they can talk to their doc and that Amazon can send them, their stuff in the mail. And I don't think we're that far away from it. The future is here. It's not evenly distributed to the rest of us yet. And the vaccine is going to be fascinating. Can't wait to see what we do. We are going to have pop-up vaccination places all over. There are going to be home-based vaccine programs. It's going to be fun to see.
Other panelists' thoughts, pie in the sky ideas with unlimited funding and no policy restrictions or regulatory restrictions?
First of all, I have to apologize that my daughter is practicing her saxophone in the background. So, but I was a little reluctant to get on. But one thing that I think the health department does very well that I would love to see scaled up is that because, you know, so many diseases and conditions are reportable to the health department, it gives us a chance to reach out to patients and have one-on-one conversations about where they are in their care, whether there are particular resources that they need, whether in certain circumstances we can, you know, do home visits or help with making appointments. You know, for reasons of patient confidentiality, anything around substance use is sort of off limits right now. But I would love to see a time when overdoses, for example, are reportable to the health department, and we could speak with people after they overdose, and you know, maybe after they've left the ED and are at a point, a juncture in their drug use after some time has passed after their overdose, where they might be more open to having someone reach out to them and offer services. So that would be my pie in the sky.
Corinne or Jermaine, any giant pie in the sky ideas?
No pie in the sky, more so increased understanding and just a smarter use of leveraging funds and resources. I just feel like there's such inefficiency around us. And if, you know, we need that one catalyst, the one who's going to bring us all together and say, you can do this, you can do that, you can do this, and together we can take care of so many different things. Like I live for that. Maybe we get that in this new administration. I don't know. I don't know.
How about you, Jermaine?
Well, to me, it's not a high in the sky idea. I think about this a lot. I mean, I would say, I mean, have at least like just 2 peers in like your ED. That's in a perfect world, right? But one thing I just would love is for like peers to be hired, like not based on record, race, educational background, right? Those people with that lived experience and empathy and like that, you know, that genuine love for people that you could see and feel, right? And yeah, but that's a perfect world. Maybe too perfect.
Not too perfect, I think. Worth working towards, as you guys are. So we've gone a little bit over time, but I just wanted to make sure that we had a time for discussion, and I apologize for those who submitted questions that Dr. Carr didn't answer personally and that I didn't get to, but I appreciate everyone's engagement and involvement in this panel, and I think we've all been introduced perhaps to some really big ideas, but also what I will say, in the words of my dear mentor and dear friend, Jeremy Nowak, in his book, in his most recent book, The New Localism, is a single line that I think just brought so much clarity to me and has become my personal mantra, which is power belongs to the problem solvers. And I think everybody on this panel reflects problem solving. And I think we've done it, as I referred to earlier, as the pivot, but I think we've all done it in a way that tries to be the most meaningful to the people that we are serving and meaningful to our community at large. And I know this audience is tremendously engaged and also problem solvers. So I thank you all. And so are there any last words of thoughts, wisdoms from the panel that you'd like to share with our audience before we sign off? Dr. Carr, I'll start with you.
The world is run by people who show up for things like this. You know, that's Jermaine, I just want to, I mean, because I have the mic for 2 seconds, say thank you. You're right. That is the ideal world where we let people in to sort of do the work that they're passionate about.
I agree. Corinne?
I don't think it's an overstatement to appreciate work that actually looks at individual people for who they are and not for a category that they fit in comfortably. So I do appreciate the work that Jermaine and his team is doing and other organizations like that. And similar to the navigators in our partnerships, you know, these people are doing tremendous work, impacting lives such that people can actualize who they're supposed to be and not be encumbered by lack of money or a preconceived notion of who they cannot be. I'd like to just say a major shout out and appreciation to all those who lend a hand in that kind of work.
Thank you. Dr. Viner?
I would echo all of those sentiments as well. I have nothing more really to add besides that. Thank you.
Thank you. Elena?
I would just say thanks to the other panelists. Thanks to everybody who tuned in tonight. And I hope to hear from many of you. And that's it from me.
And finally, Jermaine. Last bit of wisdom you want to share with us?
This was no wisdom, but this was motivating for me. Just to be on this panel with so many so many people from different aspects of the work that I do, right? And you know, just overall caring for people, and I mean, nothing really inspiring, you know, for me to close out with, other than from what I already said. I appreciate all the wonderful comments that everyone sent during the presentation. It was really inspiring. Yeah, shout out to y'all. And shout out to everyone in the panel too. I wish to connect with some of y'all all of y'all on a more personal level, outside after this. And yeah, it was real.
Thank you so much.
It was actually the event of my day.
That's good to hear. So to our the audience who has stayed with us, thank you so much for spending your evening with us. I will just point out that in this talk we have discussed HIV and hepatitis C. We have discussed the opioid crisis. We have discussed gun violence and the impact of gun violence on urban populations. And we have discussed how each of us have a voice, and each of us have our superpowers. And together, I can only say, as an emergency physician and during this time of COVID, I have, I think, been reminded of my purpose in a way that perhaps it had gotten buried a little bit, but all of you on this panel and all of you in the audience inspire me and motivate me. And I think to know that we have such an abled group with such high skills, just working where none of us can see it perhaps, but it is so reassuring to know that this team and everybody in the audience is out there and really doing everything they can for the benefit of others and the community as well as themselves. So during this time of COVID, and for Dr. Carr and I in particular, we're facing down some dark days, I think. And for the emergency physicians and other clinicians in the audience, we are sort of bracing, or it's starting to hit us already. I honor you. I honor all of your work. We are all very tired, but we are in this together. And the College of Physicians as an entity is a strong organization that dates back to the very beginnings of our country, and is sort of a model of coming together in fellowship, coming together as partners to bring our skills to the table and work to help those around us. So in that spirit, I bid you all good night. Thank you again for spending your evening with us. And thank you especially to our panelists for sharing your expertise with us this evening.